Now it is my honor to welcome our speaker, Dr. Anu Raghuram. Dr. Raghuram is a dual board certified internal medicine and infectious disease physician, currently serving as the chief scientific officer and an infectious disease outpatient clinician at the Norton Infectious Disease Institute. She earned her MD from the Universidade Federal de Pernambuco, Brazil, and completed her residency and fellowship in New York. Dr. Raghuram has held academic positions at the University of Louisville, where she directed a large HIV care center and initiated a PrEP program. She has authored numerous peer-reviewed articles on HIV, vaccines, and pneumonia. And at this time, I'd like to pass it over to Dr. Raghuram.
Hi, everyone. Can you hear me? It's great. It's great to be here. And so we'll start with the talk for today. I'm going to go ahead and share my screen. Okay, I'm going to put it on slideshow. And I'm going to swap this. Okay, everyone should be seeing the full screen at this time. Is that correct?
That is correct.
Okay. Hang on one second, because now I can't see it. I can't see my current screen. Okay, I got it now. All right, so we'll go ahead and get started. So we're going to be talking today as the first part of this three-part series about HIV transmission, pathogenesis, and diagnosis. I'm sorry that the view keeps flipping back and forth. So I'm really sorry. Let me see if I can go ahead and do this. All right. Let me know if the slide is advancing.
It did advance.
Okay, perfect. So we'll start with our objectives for today, and we're going to be reviewing the epidemiology and public health impact of HIV. We're also going to review the HIV life cycle, transmission risk, pathogenesis, and the clinical manifestations. And we're also going to go into what available HIV screening and diagnostic testing is here in the US. So let's start with the global impact and with HIV epidemiology. So these data here are from the WHO, and this is the summary of the global epidemic for the year 2023. And as you can see there on the first line, we currently have almost 40 million people living with HIV today, with 1.3 million people acquiring new infection and about 630,000 actually dying from HIV-related causes. You can also see from these data that the majority of persons living with HIV are adults that are 15 years or older, and that there's the division between women and men is fairly similar with a slight shift towards women living with HIV. So this is the breakdown of that number of almost 40 million throughout the WHO regions. And you can see that the majority of the infections currently are in Africa, with the Americas, Southeast Asia, and Europe following those numbers. And here's just a breakdown if you're more of a visual person, looking at the different geographic regions and the breakdown of the same numbers we talked about before, but this is just a good visual for you to see the numbers per region. And can you see my cursor moving on the screen? Can someone just holler out if they can?
I do not
I can
see it.
see you.
You can, okay.
Oh, I see it now.
All right, great. And then moving on. So this is another really nice chart. So when you look at this graph here, the solid blue line is looking at the annual number of people that are newly infected with HIV. And that's, you can see from the year starting in 2010. and going on to 2023. So that solid blue line is new infections, and the solid black line are the number of people dying from HIV. So you can see there's been a steady decline, and then the dashed lines are where we would be if we could maintain the current level of services. And the lines that are dropping down are the target goals for 2025, which we are now in 2025, and also for 2030. So you can see that there's quite a amount of work that needs to be done, right? We need to get from this dashed line projections all the way down to the solid lines below. And we will be able to do that with awareness and increasing the access and increasing the number of programs that provide prevention and treatment services, right? Now that we've looked at the global stage, we're going to focus in on the United States. And here what you can see, these data are from the CDC, and you can see that from 2018 to 2022, we have had a decrease, an overall decline in 12% of estimated HIV infections. And the goal is really to continue to decrease that number. And you can see the goals for the ending the HIV epidemic initiative here. The infections should decrease to 9,300 from the 30-ish thousand by 2025, which is this year, and furthermore by 3,000 by 2030. So again, lots of work to be done. And just so you can get a sense of what's driving the epidemic in the US, so most of the decline in the estimated HIV infections was really driven in the age group from 30 to 24. So you can see that 30% decrease here. In other groups, there have been decreases or stability. And then when you look at the mode of transmission, the highest decrease in individual category has been in male-to-male sexual contact. Other groups have been stable, but if you put male-to-male sexual contact together with injection drug use, that drives the biggest decrease of 27%. And estimated HIV infections has also decreased among males in that period of time. And you see it also the decrease across racial and ethnic groups, although some of these decreases have happened, there's still disparity in the number of infections in those groups. And here you can get a clearer picture of that, where you see that there has been an 18% decrease of HIV infections amongst Black or African American people. But even with this massive decrease, you still see that those numbers of infections are higher. And you also see that in other groups, this has remained stable. And since we spoke about the US, I will talk a little bit about the South. Again, you see that disparity. There has been a decrease in infections, but the overall number is still higher in the South than in other regions of the country. And just to put in perspective regarding Kentucky, the last annual report that I had access to was the 2023 report, and we had an estimated 12,000 people living with HIV in Kentucky. And of those, it was about almost 400 newly infected persons. So that's the global spectrum and the US data as far as epidemiology. So burden of disease is still pretty significant, as you can see. And as far as in the US, the estimate of people who actually know their status is about 87%. And the goal is to increase that number to having at least 95% of folks knowing their HIV status by this year, and to remain at that percentage by 2030. All right, so now we have an idea of the global impact and burden of disease. So now we're going to look into the HIV life cycle. So as you know, this is a virus. It is a retrovirus. And sorry that my slide bounced around. Okay, this is a retrovirus, right? And it comes packaged with everything it needs to be successful, so to speak, in the human host cell, right? And so here, what you see is the core of the virus. It comes prepackaged with 2 strands of RNA, and it also has 3 main enzymes that's going to help it perform all the functions it needs to within the cell. Now, on the outside of the virus, what you see are proteins, and they enable the virus to connect to its preferred cell, which is the CD4 cell, right? Once this connection happens via receptors, and you have a CCR5 receptor represented here, this connection pretty much almost physically pulls this virus inside the cell, and then the 2 membranes are going to fuse. Once that happens, this genetic material that's in here is going to be released into the cell. And what do you notice? You see that you have viral RNA, right? It's a retrovirus. It does things backwards. Normally we have DNA that then you make RNA. So here it has the viral RNA, and it's going to use its existing enzyme that's called reverse transcriptase to go ahead and look for pairs that it gets from the host to make this second strand, and now you have viral DNA. This viral DNA comes inside the nucleus of the cell, and it's going to be integrated into the host cell DNA using an enzyme that HIV virus has, which is called the integrase. Now, this establishes the chronic infection, right? Now it's here to stay. And what this allows the virus to do is it can now hijack all the host cell machinery to make its own proteins, right? So here's where it's going to go ahead and replicate, make its own proteins. It's going to make its own beginnings of a baby virus, bud over here, mature, and be released into a full virus. And you can imagine that the enzyme that does this, it also comes prepackaged, and it's called a protease. So you can imagine at each one of these steps, we have medications that can block these steps and treat HIV. However, what's already integrated into the cell, or sometimes it lays latent in certain cells, it's called a reservoir, that establishes chronic infection, and we do not have a cure for this at this moment, although there's a lot of different studies ongoing to try and address that. So that's how the life cycle works. So let's talk about transmission. We know how the virus infects a cell, but how is it transmitted? I really like this infographic from the CDC. It's very clear, and I like it for patients as well. So you can see here the mode of transmission: sexual contact, sharing needles to inject drugs, and during pregnancy or birth, and breast or chest feeding. And casual contact does not transmit HIV, so this is useful for us to pass on to patients as well. And as far as the risk of each exposure, the exposure risk is kind of broken down into 3 big buckets. One is the bloodborne, the other is sexual exposure, and then there's a category called other. So for the bloodborne, the greatest risk is really for blood transfusions, right? And that per transfusion, per 10,000 risk exposures, there's a 90% risk of transmission. And you can imagine that's why we have all the protocols in place to screen donors before they're able to donate blood, right? Because that's a pretty high transmission risk. Following that, it's really needle sharing injection drug use is the next category, followed by percutaneous needle stick and mucous membrane exposure to blood. And you can see that the risks here go down. And they're still less than 1%, and this is per exposure. As far as sexual exposure, receptive anal intercourse carries with it the highest risk of transmission, a little under 1.5%, followed by the other forms of sexual transmission, which you can see here are all less than 1%. And other things like biting, spitting, throwing body fluids, and sharing sex toys, that the transmission from those is negligible. So now we know the global burden of disease, we know the HIV life cycle, and we've talked about transmission modes. So we're going to look at how HIV actually affects different body organs and systems. So this little graph shows you exactly what we think HIV is doing inside the organ systems. So if we start here with HIV infecting CD4 T cells in the gut, and that's what happens in the acute infection phase, right? Essentially, it infects these cells here. And here you have the cell, the T cell or CD4 cell. And once it gets infected with the HIV virus, you see that they change the color. Now, there's two options once the CD4 cell, immune cell, gets infected. One is that it dies, and the other is that it stays in a dormant state with the HIV virus in it, and that's what forms our reservoirs, okay? So you can imagine that all the cell death is going to cause chronic inflammation. Now, if there's chronic inflammation, one of the signals that sends is, I have a bunch of cells here. Let me go ahead and block the formation of more cells. So it sends a sort of a blocking signal to stem cells in the bone marrow and kind of telling them, hey, don't make as many more because I already have a lot going on here, right? So that's one way that it further decreases the production of these immune cells that will help fight off infection. The other way that it can do it is in the thymus is where these cells are going to be stored. It can also go in here and infect a precursor cell here and kill it. So now you have CD4 cells being attacked on both fronts, and that's what causes the decrease in immune cell function for these CD4 cells. Now, all these signals are sending messages to the lymph nodes, right? Usually there should be a balance between cell death and cell regeneration. With all that is going on here with the HIV virus and cell death, the balance is shifted towards cell death. And so you can imagine that over time, this is going to affect a lot of organ systems, right? And that is how HIV establishes its pathogenesis. Now, what does this mean for patients, right? So here you can see the progression of the viral load or HIV viral load, starting from primary infection. So say this is day 0 here on the y-axis, on the x-axis, and essentially you start having a spike in that viral load. There, the virus is replicating. You have this big spike. This is when you have acute HIV syndrome and seeding of the lymphoid organs. And after this initial period, your immune system does try to fight back, and it is able to bring down that viral load for a certain period of time. So for a few years, it kind of is able to control the virus to some extent, but at some point after this few years, around 7-8 years, your immune system loses that battle, and then you can see the HIV viral replication resume, and you can have more constitutional symptoms and at risk for opportunistic infections followed by death. Now, what is the course of the CD4 cell count? So again, here you have kind of the opposite of what we saw before, right? You have primary infection. You start out with a normal CD4 above 1,000. During primary infection, takes that initial hit, and then your immune system starts rallying. It resets the CD4 count, but you can see here it's at a lower level than what you originally started with. And then over time, if untreated, you have a steady decline, and this steady decline translates clinically into increased risk of complications, infectious complications, right? And so you have a whole list here. I won't go through all of them, but that's essentially what would happen with untreated disease. And now that we talked about all this pathogenesis, you can see here from this picture that this is a disease that can affect pretty much every organ system. I've just listed a few things here for you to have an idea, but acute infection, you can have your flu-like symptoms, you can have fatigue. Later down the line, you can have dementia, lymphadenopathies present in acute infection. You can have oral manifestations, cardiovascular, hepatic, renal manifestations. So it pretty much is affecting every organ system, right? So that is the clinical manifestations. So now we're going to move on to the next part, which is the diagnostic and screening testing that's available. So when I think of HIV diagnostic testing, I like to kind of divide them into these three big buckets. So the first bucket is screening tests. The second is confirmation tests. And then there are some other more specialized tests that we use to manage disease. So when we talk about screening tests, this is someone you are testing to see if they have disease, right? So these tests are the ELISA tests. Most of us in clinical practice are familiar with those. We have tests that detect IgG antibodies, so already established infection, IgM antibodies, so more acute infection, a combination of both. And the more recent tests really look for both antibodies and also for antigen from the virus. So these are the combination tests that are widely used for screening today. For confirmation tests, we have the antibody differentiation test, which is what we use in our system and most of the US. Back in the day, there was Western blot was used. And another confirmation test is the actual viral load or RNA-PCR. As far as other tests that are more specialized, we have genotype, phenotype, the DNA PCR, and archive genotype. So I'll walk through each of these types of tests. So let's start with the screening tests. So here's the HIV ELISA. Most of you might be familiar with this. So this particular ELISA is what we call a sandwich ELISA, and I will show you why. And I always think of it as you're setting a trap with something to catch what you want to detect in the patient sample, right? So if you're trying to look for antibody, the trap you're going to set is the antigen. So here is a well. This is supposed to be a well with fluid in the lab, right? You have known HIV antigen here. This is the blue bars, and you're going to put patient sample in here. If the patient sample has HIV antibodies here, these two are going to connect, right? So that's what's happened here, but you can't visually see that. So you have to add something else to be able to see that that's happened. And what you add is an anti-antibody with peroxidase, and this is going to then connect to the antibody. So now, if all the stars align and everything is present, you're going to have all these three connecting, and that's the sandwich. And once this connection happens, this peroxidase is going to make a chemical reaction happen, and the color of the well is going to change. And that's how you visually see a positive test. Okay, so this is the HIV ELISA technique. Now you can imagine that I mentioned to you that the newer tests detect both antibody and antigen. So that means that when you're setting your trap here, you're going to put both antigen to capture antibody from the patient, and you're also going to put a known antibody here to capture antigen from the patient. And the rest of the process is the same. It's just what traps you're going to set here to capture what you want to see. Okay, so we're going to move along. So as far as ELISA, you might have heard of the old way that ELISA was described, right? You talked about generations of ELISA. You had the first and the second and the third and the fourth and the fifth. Right now in our institution, we have the fifth generation. The difference is really improvement in the quality of the tests and what the test detected. In the very beginning, we were only able to detect IgG antibodies, meaning established infection. And so it would take up to almost 2 months following an infection to be able to have a positive test. The second generation improved a little bit in their testing. That window period decreased to 42 days, and now you are able to detect both HIV type 1 and type 2 IgG antibodies. The third generation was the first generation where you had detection of IgM antibodies, so more acute infection. And so that window period was shortened to 22 days. Fourth generation ELISA, now you have the antigen. That's the big difference. This P24 antigen, it has very high levels at the very beginning of HIV infection. And so you can detect acute infections faster. So you can see here now we're talking about around 2 weeks between getting a positive test, between infection and being able to detect it. And the only difference between the fourth and the fifth generation is that the fourth generation will just tell me that this is positive or reactive, I should say, but it won't tell me if it was the antigen, if it was the IgM or the IgG. All I know is that one of these three is positive. With the fifth generation, you can actually know which marker was positive because they will tell you if it was the P24 antigen or not. So that's the difference, and that's what's being used across the US for the most part, either the fourth or the fifth generation. So if you see something called a combo test or combination test, that's what that is, the combination of detection of antigen and antibody. And here's just a timeline, and we already talked through that as far as the window periods for each one. The nucleic acid test is the viral load, and that's the first one to become positive within around 7 to 10 days of infection. But it's not really used as a screening test, right? That's more of a confirmation test. And here's the new way you're supposed to refer to the ELISAs instead of calling it first, second, and third, and fourth and fifth generation. There's a blurring of the lines, especially between some of the older tests. So now we just call them IgG sensitive and IgM sensitive or antigen antibody, which is what we currently use. So those are the screening tests. So let's talk about the confirmation tests for HIV. So the confirmation test that's currently available that we use is this antibody differentiation test. This can detect both HIV-1 and HIV-2, and they're looking for IgG antibodies in this case, okay? As you can see here, there are 4 different proteins it's looking for HIV-1 and 2 different ones for HIV-2. And the diagnosis is made for HIV-2, you must have both bands present. For HIV-1, you should have either GP160 and GP41 positive, these two, which are envelope proteins, or one of them plus a non-envelope protein. So, and this test is not like a simple, you pour the sample in the well and then you read it with the naked eye. You have to actually put this cassette into a computer and it detects the changes in the bands and reads it for you and gives you the diagnostic result. And that's what we use currently. Back in the day, we were using Western blots, right, to confirm. But as you can see from the picture here, it's a very complex and laborious process, and it takes time and can be costly. So now we're largely using the previous test I showed you, which was the antibody differentiation test. And this is kind of the time to positivity after infection for the different tests that we talked about. So we said before that the viral RNA or viral load is the first one to pop up. Again, this is very specific test, and you're not going to do it as a screening test. The second one to become positive is that P24 antigen we talked about around 2 weeks after infection, followed closely by the ELISA and followed closely by the antibody differentiation test. And then there's a rapid oral swab. And in this study, they were looking at an older generation, like an IgG based test. And then the Western blot here is kind of the last one to become positive. It does look at almost 10 bands, different bands. So, it is looking at more bands, but it's also more labor intensive, and it becomes positive the latest. So that's the timing of those tests for them to become positive. And here's just another depiction of time to positivity. We already talked about that. And this is a graph from the CDC with that same data, just so you know the time to positivity of these tests. Now that we know what tests are used, this is the testing algorithm that's recommended by the CDC as well. And so when you screen someone, you start with that combination test we talked about, right? The antigen antibody assay. If it's negative, that means you didn't find any antibodies or antigen for either HIV 1 or 2. If it's positive, then you need to confirm that. And you confirm that with the HIV 1 and 2 differentiation assay. And that's that little blue cassette that I showed you before, right? And of course, depending on what turns up positive, you will have either HIV 1 or 2 or both. But sometimes this can come back with an indeterminate result, right? So if that happens, you now have two discordant tests. And when you have two discordant tests, you need some type of tiebreaker to figure out what's happening, right? And that's where you can do the viral load. And if that is positive, that is indicative of acute HIV infection, just based on the timing of positivity of the test, as we saw previously. And if it's negative, you don't have HIV. Now, that's with a caveat, right? What happens, there's a couple different possibilities, right? When you get discordant tests. Usually when you have discordant tests, you use your tiebreaker and you take the majority wins, right? So if you have two negatives and a positive, you're going to say that this is negative. Now, there are a couple of different clinical scenarios that you can see here. One is that when you have discordant tests, one possibility is that one test is simply a false positive or a false negative, and that's a possibility, right? The test is wrong. The other possibility is that we do have a special subset of HIV positive patients called controllers, and they're able to actually suppress the virus on their own without medication. And so these patients tend to have a positive in combo tests. They tend to have a positive confirmation, but then they have a negative viral load. Or sometimes they'll have wonky discordances where this might be indeterminate. So your job really in the clinical space is to make absolutely sure that this person with discordant tests does not have HIV, right? So one of the ways is to look for the viral load. If you still have doubts, there's a few other specialized tests that I will talk about shortly that can help you distinguish that. Okay, so just remember when you have discordant tests, make sure it's not an acute HIV infection. And if you still have doubts about this, obviously always call your friendly ID specialist and they'll help you out. But know that there are other specialized tests that you can use. Okay, so let's talk about these other HIV tests, right? So the first one I'm going to talk to you about is called a genotype test. And this test really is helpful for HIV positives that have been confirmed as positive and you're starting a treatment course and you want to know which medications work for that patient's virus. Do they have any resistance to particular medications, right? So that's what the genotype test is. And essentially in the lab, you're going to collect the patient's sample. They're going to extract that virus in the lab, amplify it, and then they're going to put down what the genetic sequence is for that virus. Then every lab that does resistance testing for HIV in the country has a sequence of what we call the wild type virus. And wild type virus is just an HIV virus that has no drug resistance mutations. So they're going to have that sequence and they're going to compare it with your patient's virus. And wherever there's a difference, wherever there's something that's not adding up, that's a mutation. So they're going to take note of these mutations and they're going to compare to a big database that exists where all these are collected. Some of these differences are not going to mean anything, but others are going to mean that a drug does not work. And so they're going to take all that, compare it to the large databases that exist, and they're going to give you a test report that's going to tell you drug A works, drug B doesn't work, or all drugs work. And this is all based on this comparison to a database, right? So that's what a genotype test is. And the second test is fairly similar. It's called a phenotype. The initial steps are very similar. What's different is these later steps, right? So after extracting the DNA and amplifying it, they're actually going to assemble a HIV vector, and they're going to infect a little lab cell and make a whole bunch of new little viruses here. Then they're going to take these viruses and they're going to put it in these wells. Each of these wells will have a particular HIV medication or antiretroviral, and they're going to see how well that medication kills the virus. And they're going to generate a report. Now, you can see from the difference here between the phenotype and the genotype, right? Genotype was comparing to an existing database and comparing mutations. This one's actually getting the patient's virus and seeing how well that drug works for the virus. So it's more specific and tailored to that patient's virus. And it will almost like when you're looking at antibiotic resistance, right? The report will tell you how susceptible some bacteria is to an antibiotic. It's the same kind of principle. So you might have a question, well, why do we do genotypes at all? Why don't we just do phenotypes on everybody? Because you get better information. Well, the thing is, most of the time, you're going to get the information you need from a genotype. And secondly, you can imagine that a phenotype is a lot more expensive, right? So we reserve the phenotype to when patients are not responding to therapy as expected. And that's when we deploy phenotype testing, okay? So that's the phenotype. And then the other set of tests are the DNA PCRs, okay? We talked about special populations that can maybe suppress the virus on their own without medication, and you won't see a viral load. So how do you know that if the person is just not infected at all, or if they're the special rare population? So there is a way to actually detect that proviral DNA that I talked about when the virus integrates into the whole cell DNA. So there's a way to extract that and find that. So this is the hidden virus, right? So you can detect that. And if you do detect that through testing, then you can say that the virus is present in the body. Whereas the viral load is kind of outside in the blood cell. I have a picture coming in later, and that is in the blood circulating, right? So that's easier to measure and detect. And this is harder to extract, but you can extract it this way. That's what's called the HIV DNA PCR testing. And sometimes in babies born to moms that are positive, they will try and use this because the circulating plasma will have mom's viral load potentially, right? So you can use this in babies for surveillance and diagnostics. And the last test I'm going to talk about is the using this principle of this DNA PCR is called an archive genotype testing. So you already have an idea of how a genotype works. So now we're going to talk about this different test called an archive genotype. Okay. So essentially, we talked about plasma RNA, and that's what's the viral load. It's actively replicating virus in infected cells, and it's the most current form of the virus. The archive DNA, we kind of saw a picture of that in the previous slide. This is the virus that's transmitted and archived during acute infections, and it preserves the mutations that were acquired then. And this is a picture for you to help you understand a little bit better. So if this is your blood cell here, blood vessel here, you have the purple cells are the HIV infected cells. The little green stars are the actual HIV virus. So if you have this circulating in the blood, you can easily measure this, and that's what gives you the viral load and the amount of copies per ml of viral load. Now, say somebody's undetectable, right? They're either on treatment or they're that special population of controllers. This won't be present. You won't be able to measure this. However, you do have these HIV-1 infected cells where that DNA is present and where the virus is latent. So that's what you're extracting here in this archive genotype test. And what's the use of this? One, you can find that archive proviral DNA. And two, if you think of the course of HIV, we do have patients that have survived for a very long time now, right? And back in the beginning of the epidemic, genotype testing wasn't available. So we may have patients that are on an old regimen, or they want to change regimens because they want less side effects, or there's drug-drug interactions, and you don't have the information on what drug will work for them to make that switch. So in those cases, you can do this testing and get a genotype result and help you decide what medication would work for your patient. So that's one use of them, but this is a very specialized type of testing that you won't really see in just general practice, right? And this is just showing where that cell-associated DNA comes from. In some other testing, like if you've heard of maternity testing for, that gives you the risk of, it tells you the sex of the baby, but also gives you the risk of certain genetically transmitted diseases. That one also uses a similar technique, trying to find the cell-associated DNA. So we already talked about those compartments, and this is just a depiction of how archive genotype testing works. So the initial steps are extracting that DNA, amplifying the DNA, and here you put it in this machine that's going to do the genetic sequencing, and then it does give you a result similar to what I talked to about the traditional genotype, where they're comparing it to a database. Then they are going to interpret that and put it in a report for you. So these last tests we talked about are the more specialized tests that we use for management of HIV. And I think that's the last one on testing. So I will go ahead with the summary. So we saw through this talk that HIV infections still have a very significant global impact. The continued decrease in HIV transmission is going to be dependent on these expanded awareness and prevention efforts and increasing services for patients. We also saw that HIV establishes a chronic state of inflammation and CD4 depletion, and that's what ultimately affects your capacity to fight off infections. We saw that there are multiple options for screening and diagnosis of HIV, and knowing those different modalities is important in the case of these, particularly in the case of these discordant tests, because that does need further workup. And lastly, just knowing the full clinical picture, exposure, history, clinical history of patients is really essential in helping you figure out which type of testing you are going to do. And that is all I had for you today. So I'm going to pause here and I will wait for the moderators to let me know what's next. Thank you.
Thank you very much for that presentation. It was fantastic. We do have a couple of questions. Um, what do you think had the biggest impact on the decrease in HIV in the 13 to 24-year-old age group?
Mm-hmm. That's a great question. I think just in general, I think that population is more connected and aware of things, even amongst my patients that come to me for PrEP, a lot of times they have heard about it. And also it's the efforts of disseminating the prevention strategy, right? There's been a lot of work with this from the CDC, WHO, which is disseminating that information and bringing that information out there. But I think it's a combination of those two things and many other factors.
Is there discussion about incorporating testing for HIV into the a comprehensive STI panel?
Meaning as an order set, or are we
Um,
talking about just the regular screening test?
yeah, I suspect that's the case. Yeah. Just like as a
Okay.
general, like if testing for STIs, including HIV as well.
Mm-hmm. I think that is more of an admin type clinical concern. It varies very much by state and by institution. So I know there have been talks about this. I don't know that I can tell you when that resolution is going to be there yet.
Sure. Um, with the advancements in testing and ability to diagnose sooner, is that changing the medications we use to target a different part of the HIV pathogenesis process?
Mhm. That's a great question. We will be talking a little bit more about management in the third session of this series. It does definitely help start treatment sooner. We do a lot of what we call rapid start today. We actually, some of those tests I showed you, like the genotype and phenotype, those results take a good 3 weeks to come back. So we are not waiting for those results to come back because today we have many options that we know are going to work. It's more of a backup to make sure it's not a weird resistant virus, right? So it does help that strategy to start treatment earlier. And that's very important because the earlier you start in an acute infection setting, that decreases transmission in the community too, right? Because at those high viral loads, you can imagine transmission is going to be much higher as well.
What do you think the gut biome's impact is on HIV infections?
I think the gut microbiome has a very profound impact, not only in HIV, but pretty much any disease that you can think of. Um, as you saw in that little picture where we had like the gut cells, right? That is where HIV first establishes infection, right? And the gut microbiome, it's not just a combination of good bacteria, right? There's a lot of signaling that happens in a healthy microbiome that tells different inflammatory cells to come up or not, or blocks certain things. So it's a very complex interplay of signals there. And I, the microbiome pretty much is regulating all those immune responses. So I think it has a very large role in that. We are exploring that in many ways. And we actually have a PrEP study ongoing in our institution that is exploring like the medication impact on microbiome and how the microbiome affects disease patterns and so forth. So I think it has a major role.
And then just one last question. Can you elaborate on recommended populations to be tested, frequency of testing, or CDC recommendations?
Sure. So Anybody between ages 13 to 64 should be tested once in their lifetime, right? So that is the recommendation from the CDC. Then when you look at other groups, so if you have unknown status sexual partners, if you're not using condoms, or if you're sharing injection drug equipment, any of those categories should be tested at least every 3 to 6 months, right? Based on risk. So those are the recommendations.
Great. I think those are all of the questions that I see thus far. Looking forward to the next presentation that we will have around pre-exposure prophylaxis next Thursday to tie into all of this. So thank you very much for joining.